and Happy New Year to all. And I am Dr. Sudhakar Jonnalagada, President of the American Association of Physicians of Indian Origin. Welcome to RP Chicago Medical Society CME webinar program today. This program is structured with exclusive format of involving AHA, American Heart Association leadership, and resuscitation experts. I welcome our chief guest today, Mr. John Miners, and distinguished speakers, Dr. Ashish Panchal and Dr. Alexis Topjian. Greetings to all our participants, including our guests from India. I would like to recognize few honored guests involving the resuscitation program in India. Dr. Sachin Menon, Consultant Regional Director of AHA. Dr. Chakra Rao, Chairman, Indian Resuscitation Council. Dr. G.V. Raman Rao, Director, Emergency Medicine Learning Center and Research, GVK Emergency Management Research Institute, Hyderabad. Dr. Srinivas Ramaka, Cardiologist and Resuscitation Researcher, Warangal, Telangana. And Dr. Arunachal Ramesh, the Program Director, Heart Rescue India, Bangalore, Karnataka. I thank today the speakers and moderator and Program Director, Dr. Vemuri Murthy, Adjunct Faculty, Department of Emergency Medicine, University of Illinois and Chicago College of Medicine, Chicago, and Chairman of RPCME Webinar Committee, who is involved with Indo-US Resuscitation Program for several years with organizing this program. I request all enjoy the workshop. Good evening.
Thank you, Dr. Murthy. Good evening. Today's CME workshop on Resuscitation Updates, 2020 AHA Resuscitation Guidelines, is a timely, informative presentation on adult and pediatric resuscitation by the American Heart Association experts. My presentation on cardiac arrest registries will follow a couple of presentations ahead of me. A 15-minute time-limited question and answer session will entertain a few randomly selected questions from the chat line. Today's program is accredited for 1.45 hours of AMA Category 1 credit approved by the Chicago Medical Society. It's now my pleasure to introduce our chief guest, Mr. John Miners. John Miners, Chief of Mission Aligned Businesses and Healthcare Solutions for the American Heart Association, leads the development and expansion of the association's businesses that support its global mission to reduce mortality from cardiovascular diseases and stroke by 25% by the year 2025. John oversees several revenue-generating mission delivery departments at the association, including emergency cardiovascular care, workplace health, international programs, and quality systems improvement. The emergency cardiovascular care business is comprised of more than 4,000 training centers and 450,000 instructors who train 22 million people per year in more than 100 countries. Additionally, he leads the development and expansion of the American Heart Association's international mission through groundbreaking collaborations with Fortune Global 500 companies, creating shared value for both. Thank you, John, for joining us.
Well, thank you, Dr. Murthy, I greatly appreciate the opportunity to be with you all this morning or this evening, depending on where you're from. I see many familiar faces in our work with the American Heart Association around the world. So Happy New Year. And I look forward to sharing a bit more about the American Heart Association and our work around the world. The other speakers today will be well prepared to talk about the guidelines in particular, but I thought I would spend time talking a bit more about the global mission, cause, and bring you up to speed with some of the recent activities of the American Heart Association and our work outside the United States. And particularly as it relates to the topic here of resuscitation. The American Heart Association, you may not know, recently changed its mission statement. This is a pretty major change for an organization that's almost 100 years old. But last year, we broadened the scope of our work, and you'll see here on the slide that to be a relentless force for a world of longer, healthier lives. The two major changes here from our prior mission statement are, you don't see it just focused on cardiovascular disease and stroke, right? So we're talking about much more focus on prevention, and longer, healthier lives really opens up the possibility for us to work more cross-collaboratively, more across all disease states, because as you start to look at preventing disease, the risk factors start to line up for all the major diseases. So that was part of the thinking there. And second, this is the first time in our history, almost 100-year history of the organization, that we have the world as part of our target and focus. Much as that has been the growth over the last 10 years, and some of the people on this call that have helped us in expanding our work, building partnerships and collaborations with now more than 200 sister societies, foundations, and ministries of health around the world. What we call our value proposition is how we see ourselves going about this work. And we see that as being a catalyst for equitable health and well-being in the US and around the world, anchored in our history of cardiovascular disease and brain health, but continuing to focus increasingly, not just on interventional work, but prevention. I probably no need to share this slide with this group, but the understanding of the burden of disease for cardiovascular disease, as this slide from WHO kind of represents. The United States isn't the place anymore where the greatest burden of non-communicable diseases are. It's in many other parts of the world, and as non-communicable diseases have declined, and you see in the chart on the left, non-communicable disease continue to be on the rise. And I think one of the most important parts of this is the inequities and the disparities in burden of disease is becoming wider and wider. So this is something the Heart Association is extraordinarily focused on now, is health equity in the United States and around the world, focusing on ensuring that we don't further grow unanticipated the haves and have-nots when it comes to access to health and health care. So a few numbers as we talk about resuscitation. Vimiri knows this program well and has been instrumental in helping us establish this, particularly in places like India. We have about 40,000 instructors outside the United States, 450,000 instructors inside the United States. As you mentioned, this slide's a little dated. I think last year was 24 million people were trained in various forms of resuscitation, from advanced cardiac life support, pediatric advanced life support, to basic first aid, CPR, and even CPR in schools. We were recognized several years ago that really getting the next generation to see this as a life skill. It's similar to reading, writing, arithmetic. Why shouldn't everybody be prepared to save a life? So that's now a critical part of our training curriculum in many countries. You can see the countries in red here are where we have established training centers. In fact, many of our courses now are offered in a digital format, and we have sold online courses in more than 180 countries. But the ones represented here where we have formal authorized training centers that can do skills evaluations, certification, and the like. I'll also mention, some of you will be familiar with our newer solution, I'll talk about it in a minute, resuscitation quality improvement, where we're moving from mere compliance and training to verified competence of healthcare providers. And we currently have 1,800 hospitals in the United States, and actually about a dozen countries that have begun implementing it. One of the unintended consequences and unanticipated consequences of COVID-19 was the need to find ways to maintain healthcare provider competence, but in a socially distanced and automated fashion. And RQI and our digital courses were just the ticket to help healthcare providers and institutions continue their very important work in maintaining healthcare provider competence. So transitioning a bit to the guidelines, again, I'm not going to talk about the specifics. Those will be covered later by your other speakers. But I wanted to talk a bit about the history. You know, when CPR was developed in the 1940s, the AHA was very involved in the very beginnings. And the very first CPR guidelines were published in 1966. And we've reviewed, updated, and published periodically ever since. More recently, the guidelines were kind of revisited every 5 years. In the latest years, we've had interim updates, and we're trying to become much more agile and rapid cycle with, as new science is developed, updating the guidelines in a very frequent fashion. The International Liaison Committee on Resuscitation is familiar possibly to many of you. AHA co-founded this with the European Resuscitation Council in, I believe, 1972 to bring, 1992, to bring the resuscitation groups around the world at that time, and continued to together to look at building consensus and arrive on consistency and hopefully some type of guiding principles around resuscitation. So ILCOR, we're very proud of its history. You see here the organizations that are part of the International Liaison Committee on Resuscitation. The AHA is the only US member of ILCOR. The AHA's had a pretty, I mean, there's many things the American Heart Association is known for, such as our public policy work, our research efforts, our public education efforts, but the CPR guidelines is to this day one of the things that many people most think of when they think of the American Heart Association. And I think part of that is due to our work globally to build consensus and support the guidelines and efforts to implement resuscitation throughout the world. And the latest release, the 2020 guidelines, is no exception. You know, in spite of all the challenges of COVID, we were able to release the guidelines on time this past October, and we were thrilled to be able to do that due to the great dedication of so many volunteers who, you know, in spite of the distraction and all their other efforts, endeavored to make this life-saving new information available. This is a bit of a timeline. I've mentioned some of these pieces of the history, you know, from the time CPR was created and the initial guidelines. Then to beyond the guidelines, we realized that that we needed to do more than just publish guidelines. And that's when, in the 70s, we started building training programs to ensure that that information was getting put into practice. And through the evolution of time, you see, grew from advanced cardiac life support to basic life support, neonatal resuscitation, et cetera. In about 2005, we expanded then to the lay population and first aid and CPR, getting further and further upstream in the chain of survival to where first responders would be trained to start CPR sooner. Even more recently, we've focused on training for 911 emergency operators to coach, bystanders in starting hands-only CPR. And then finally, you'll see in 2014, we launched the Resuscitation Quality Improvement Program, which we think is the gold standard now in resuscitation training, moving to actually verified competence. And healthcare providers each quarter going through a very brief skills refresher and assessment on a simulation cart. So I think as I start to close here, I think I want to mention that we think the time is now for digital solutions and enhancing our instructor-led activities with the opportunities that technology brings to us. You see here a picture of the RQI station. And as I mentioned, we now have 1,800 hospitals in the United States, including every one of the U.S. Veterans Administration hospitals that have converted their training to this now verified competence solution. There's still a need for instructor-led training in certain cases, but we think that this solution that brings the cognitive learning and the skills practice to another level of granularity is probably the future. We started with e-learning about 10 or 11 years ago, and courses we call heart code. That's great for the cognitive learning, but we all know that resuscitation is a psychomotor skill. So the compressions, the ventilations is something that is a skill that needs practice. And so this is where we partnered with Laerdal Medical and others to develop this high fidelity simulation solution. And I'll leave you with a thought that one, not only is this these new automated solutions, more appropriate in a COVID, sort of world, we're finding that they're more efficient. Healthcare providers need to spend less time in the training environment. They can do this at, literally on the ward in less than 10 minutes once a quarter. So it's saving them time and resources by not being away from the bedside. Most importantly, we're finding healthcare providers are more competent in high quality CPR as a result of practicing more frequently, and they're more confident. We're actually hearing from chief nursing officers that their staff are much more confident in their abilities to do and perform resuscitation. So both of those are the things that we see as the next evolution in the delivery of translating our guidelines, into actual practical training solutions. So with that, I thank you. Thank you very much, Dr. Murthy, and it was a pleasure being with you tonight.
Yeah, thank you, Mr. Miners, for your vibrant presentation summarizing the mission and vision of the American Heart Association. Well, I feel that given the manpower, resources, and infrastructure unique to the American Heart Association, we hope to see a significant reduction in the global morbidity and mortality due to cardiovascular disease and stroke by the target year, 2025. We really appreciate your participation today. Thanks again. Our next distinguished speaker is Dr. Ashish R. Panchal. Dr. Ashish R. Panchal is Professor of Emergency Medicine at the Ohio State University Wexner Medical Center. Dr. Panchal is board certified in emergency medicine and emergency medical services, and is heavily involved in pre-hospital care as an EMS medical director and the research and fellowship director for the National Registry of Emergency Medical Technicians. His research focus areas include cardiac resuscitation, pre-hospital workforce, and wellness. Dr. Panchal is a member and vice chair of the American Heart Association Emergency Cardiovascular Care Science Subcommittee and the chair of the 2018, 2019, and 2020 AHA ECC guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. We welcome you, Dr. Panchal.
Thank you so much for having me today. This is great. I'm so pleased to be here and be able to talk about something I really am passionate and I love a ton, which is resuscitation. I think one of the realities that we are facing now, the more and more we talk about resuscitation, is that this is real and that we can actually save lives and it actually works. And so what's exciting for me is through our guidelines, we're able to move forward what we're doing on a daily basis and truly have an impact on every individual we see as clinicians. So let's talk a little bit about this. So I think I'm singing to the choir right now that cardiac arrest is a leading problem for morbidity and mortality in the United States and across the world. Here I have some statistics from the United States, but to be more legitimate, I think the concept that we need to really focus on is this is not just a one location problem. Worldwide, we know 17 million people have cardiac associated death, and about 25% of these are directly attributed to cardiac arrest. So this is an unbelievably large problem across the world that each of us, no matter where we practice, we're going to be faced with this. Now, one of the big challenges I think that we all have in our clinical practice is that much of the variations in cardiac arrest survival may be actually due to the strength of our chain of survival. So the chain of survival are all these critical actions that we need to do and have to occur in rapid succession to maximize the chance of survival for one of our patients or victims from cardiac arrest. So here's the classic image of the chain of survival that we see everywhere. We see the concept of early activation of emergency response, performance of high quality CPR with defibrillation, and then the arrival and care with advanced resuscitation, and even in hospital care, which becomes critically important. All of these steps have to work together. But the challenge is that anytime you have challenges within the links of survival, that's when we see dangers where people may not have the most optimal outcome. And so that's our goal. Our goal is to strengthen these chains. Now, the 2020 AHA guidelines provides a comprehensive review of all the evidence-based recommendations for resuscitation and emergency cardiovascular care so that you can look at each of these chains of survival and look at the cornucopia or all those different things that you have available for you so that you can start building up strength in those chains. Now, in 2015, we were on a 5-year update cycle, and we transitioned from that to a continuous evidence evaluation rather than these large periodic reviews. And so you'll hear us talk every once in a while about focused updates. And the reason behind this is that the data is coming out so fast. We are able to gather data, look at randomized controlled trials, and really have a change in our practice so quickly now that it's amazing to see how fast we grow and change and how resuscitation changes. So this allows for these significant science changes to be incorporated very, very quickly. Now, one of the big things is, though, that every once in a while, you need a refresher. You need to see the whole package put back together. And that's what the 2020 guidelines is. It was a comprehensive review of all the extensive data, and it was done at an international level. It was all done in conjunction with ILCOR, as well as affiliated international liaison councils and resuscitation member councils. And so we leveraged a number of different evaluation types. We looked at systematic reviews, we looked at scoping reviews, and even evidence updates to gather the best possible data so that we can make these determinations. Now, I think this is one of those figures that is so unbelievably busy that no one ever wants to talk about it, but I think this is the exciting one because it tells us about the amount of work and effort that goes into the point where you start with formulating a question up here on the left corner, all the way to generating grade level recommendations after the panel has actually looked at all the summary of the data and determined that this data is good data or it's downgraded or it's upgraded. And then you sit down and you actually say, well, this is what we recommend after looking at everything. And so this is the exciting process that occurs behind those closed doors. Now, in the 2020 guidelines, I am floored to be able to say that we went through a huge evidence evaluation to the point that you have so much new data and so much discussion that we have 491, and this is the total in the corner here, updated and new recommendations. And this is across all the different areas of the guideline process. So you see across the top, ALS, PEDS, neonatal, resuscitation, science, education, as well as systems of care. So a very large, expansive evaluation. Now, one of the things that I do want to draw your attention to, which is one of the things as a resuscitation researcher myself that I pay a lot of attention to, is this column right here under level and quality of evidence. Notice that A and B level quality evidence is only around 12% total, and A is only 1%. So as resuscitation researchers and as advocates for our patients, we still have lots of work to do. There's still lots of good work to make strong definitions about exactly what care is like and how we perform that care. So we'll get there, but it's important for us to delineate out what that looks like. Now, one of the big changes in the 2020 guidelines is the use of an updated modular chunk format. So this is a different appearance of the guidelines if you guys have taken a look at it. And the reason behind this is the goal is to make these discrete modules so that you have specific topics and management issues which are more compressed so they're more readable. And this was all based off of Levine's landmark paper where he describes how we can put this together. I'm going to show you a little bit about that. So the intention of this format is to make the guideline recommendations much more transparent so you can actually see it and deal with it. And you want to make it focused on those recommendations. And the second is to limit the text. Previously, we had these large drawn out chapters, and now this makes it much more clean so that a lot of individuals who are maybe looking at it through a mobile device have a much easier time of getting into the data and understanding what's being said and why. So again, the primary goal ends up being this simple concept. We want to facilitate dissemination and implementation of these life-saving interventions. And I think that's all what all of us want. And so this is an example of mental health and neurodevelopment issues. So nothing to do with cardiac arrest, because I just want you to focus on the format here. And here what you have is a standard modular chunk where on the left, you have a nice little table, which gives you class of recommendation, level of evidence, and focuses again on the recommendation itself, a little synopsis of the topic area. So if you just want to get your head around exactly what we're talking about, and then recommendation specific text, which supports each of these recommendations. So it gives you clear, quick, to the point concepts of where this data comes from and why it's important. So now I'm going to transition a little bit. We're going to start talking a little bit more about the guidelines and specifically about the 2020 adult guidelines. I'm excited to be able to talk about this section because what Alexis does, I don't think I could ever do it near the justice that she'll do for you today. So we'll talk a little bit about adult and go from there. Now, the key concepts I want to address are these 6 areas. There were over 260 new and updated recommendations in the adult section alone. And so it'd be really hard for us to cover all of those today. So with that in mind, I'm going to highlight some of the key aspects that are critically important in the discussion. And then what we'll do is go into a little more detail on each of these areas. We're focusing on some of the visual aids and algorithms. And hopefully that'll give you kind of a taste of what's there for you. So first of all, I think that one of the most important and most exciting concepts for me is the reaffirmation of some of the core key concepts that drive the fundamentals of resuscitation. So even after these huge drawn out evidence evaluations where we've done huge reviews of large amounts of data, the fundamentals are still true. We reaffirm the importance of bystander recognition, early high quality CPR, and defibrillation of shockable rhythms. The numbers that we always talk about, like 2 inches of chest compression depth, 100 to 120 of rate, those are all still true. And the focus on high quality CPR is still critically important. So reaffirming these core concepts and what we train everybody to do every single day is still one of the most important things. And we see these in our algorithms themselves. So this is an updated adult basic life support algorithm for healthcare providers. In here, you see that I've highlighted the areas where recognition is in the center and focus of it, and followed by, once you've made your recognition of the event, to move quickly into CPR and defibrillation. Again, highlighting the things that we can do to save a life. Now, another big update is again reaffirming the use of epinephrine in resuscitation, and this is a class 1 recommendation. Now, for me, this was particularly important being a pre-hospital provider and seeing all the data coming out about epinephrine and lots of discussion on the blogs about whether or not epinephrine is even useful or should we even be considering it. And a recent large RCT evaluated the use of epinephrine. The key findings are that it increases survival. Now, we recognize that overall survival is poor and the impact of epinephrine itself on neurological outcome is still a question that needs to be answered, but that's in the setting when drug administration is prolonged. That's an important concept, is that when drug administration is prolonged, survival is definitely poor when it comes to epinephrine. Now, let's take that into context. The context I want to give you is that if you give epinephrine early, we expect that you may probably have actually a better outcome. And we're seeing that in some of the prelim studies. So here is the updated adult cardiac arrest algorithm, where you start with CPR at the top. And of course, you do your rhythm check. But imagine if we go into VFib, a shockable rhythm. In that shockable rhythm, I think we all recognize that defibrillation is going to be the core of that for survival. And of course, that is featured really early here, and it's really a focus. On the other side now, when you look at asystole, which I think we all recognize there's not much we can do until recently. The epinephrine data definitely tells us that early epinephrine, or epinephrine for this group at all, is what gives us good survival. And hence, early epinephrine is a highlight of this algorithm. We also realized that as we're going through all this data, resuscitation of patients, they're not identical. That specialized management may be necessary for specific patients. It's just so we can make sure they have the optimal outcome. Now, as an example, in this guideline, we present new algorithms and guidance for a number of areas, including cardiac arrest in pregnancy and opioid-associated cardiac arrest. So let's touch base on those two topics. So the first is cardiac arrest in pregnancy. This is always a challenging clinical space that we would have to face anytime you have a patient who is in cardiac arrest and also who is also pregnant. The highlights that we have here in this new algorithm is, number one, team planning. We all recognize that we need strong team collaboration to work together for these patients, because in truth, we do have two patients that we're trying to take care of here, and that we need to prioritize both patients. So you can see in this algorithm, we have a maternal interventions on the left and performing obstetric interventions on the right. And included in these are the use of lateral uterine displacement and, of course, perimortem delivery, because perimortem delivery itself can have benefits not only for the baby, but also the mother's resuscitation. Now, concerning opioid-associated cardiac arrest, we recognized in this guideline process the large burden of disease of the opioid epidemic and the increase in opioid-associated cardiac arrest. So we featured an in-depth evaluation of the literature associated with this disease process, and we provided two new algorithms which leverage the evidence evaluation of a new scientific statement on opioid-associated cardiac arrest. Now, here is one of the example algorithms. I'm showing you only one, but this is the opioid-associated lay responder algorithm. Now, the highlights of this specific algorithm focus on the recognition of two different conditions. One for cardiac arrest, where the mainstay of care remains the initiation of emergency response and performance of high-quality CPR over here. And for respiratory distress or failure, where a big part of this is to prevent the deterioration and to provide early naloxone if available. Now, one area I wanted to toss in here, just because this is something a lot of people have talked about, is the use of double sequential defibrillation. We've seen this a lot in the pre-hospital state, but we've also seen this increasingly occurring in the in-hospital state. So what is this? This is basically giving shocks simultaneously by two monitor defibrillators with pads placed in different areas. Now, a large systematic review was done, which recommended against routine use of double sequential defibrillation. Now, currently, there's a large RCT being done, and the pilot data is also being done, which is looking at the comparison of double sequential defibrillation versus alternative pad placement. So we still have a lot of unanswered questions concerning DSD, including the timing of these shocks, pad positioning, the technique, and whether or not there's harm from increased energy. So at this time, again, we cannot recommend routine use of double sequential defibrillation. The other big area that we're moving towards is thinking about, again, our chains of survival. And one chain specifically is post-resuscitative care. It's optimizing this process. So for all patients, no matter the cause of arrest, our goal is to optimize that survival. And it's critical to optimize what we do in the post-resuscitative state, because then we can ensure better functional outcomes. So in this guideline, we provide a new cardiac arrest algorithm, which features an initial stabilization phase at the top, as well as continued management down below. And in the continued management, you can imagine things like, do we need to provide mechanical circulatory support? Do they need to go to PCI? And of course, TTM, continuous EEG monitoring, or other critical care management. Now, in the initial early stabilization phase, I think this is truly important, is that once we think that somebody has obtained ROSC, what are the different steps we need to do? For instance, optimizing their airway, managing their respiratory parameters, and even managing their hemodynamic parameters, and getting that 12 lead early so we know whether or not this is a STEMI or not, since a lot of times STEMI is something we want to intervene on. And with that in mind, one of our recommendations was to look at the concept of PCI after cardiac arrest. And understanding the use of PCI in these patients is important for transport decisions. And we recognize that PCI after ROSC is strongly recommended for anyone who has a STEMI, and it's reasonable for people who are unstable after a cardiac etiology event. Now, with all the post-ROSC care that we are talking about, one of the other major areas that we need to really think about is, what do we do with the patient after they have ROSC, and we're trying to understand what their survival is like. And a big part of that is neuroprognostication. Now, this is a really challenging area. Accurate neurological prognostication is important for us to avoid the inappropriate withdrawal of life support in patients who could actually have meaningful survival. There's a number of papers which have looked at the question and have shown that many times we make these decisions within 24 hours. And so one of the key aspects that we need to think about is that we need to take a multimodal approach to neuroprognostication. And in this guideline, we present a new schematic for neuroprognostication, which incorporates not only imaging, electrophysiology, clinical exam, as well as biomarkers. So here is a figure of the schematic from the guideline itself. And you can see how throughout this process, we have the time along the bottom where you're 24, 40 hours and 72 hours, and each of the different imaging modalities throughout, or electrophysiology and so on. Now, in the guidelines, we have gone through all these different areas and many, many different reviews of all the different components used in the different biomarkers and clinical exams. And many of those are listed here so you can see them. But the key aspect here is that we have a strong stance here that incorporating all of these diagnostic tests in a multimodal approach at least 72 hours after normothermia will help make a more clear vision of a neuroprognostication decision. Last but not least, I think one of the most important things is really looking to the future of our survivors. We have all worked really hard to improve outcomes and recognize there's a strong need to focus care on our survivors, because amazingly enough, there are survivors. There's lots of survivors. And this is the exciting part of what we do, is that we're seeing over time that a difference is truly being made. In this guideline, we leverage a new scientific statement on survivorship and recognize that recovery is real, but it requires organized planning to optimize a patient's outcome and their transition to home. So we have patients who have had a cardiac arrest, have been optimized throughout the chains of survival, have made it to recovery, and now we have to help them recover. We need to support them through their pathway, because it is truly a pathway in a direction. And so we highlight this with the addition of a new chain of survival, the recovery chain of survival. And so when we look at this concept, the roadmap to recovery are multiple different steps with different goals at every step. It could be anywhere from the ultra short-term time period all the way to the medium-term and even long-term time period. But the things that you're going to face in each of these periods is very different. And so recovery and survivorship plans are there to help guide not only the patient, the caregivers, as well as the primary care providers. And it gives an idea of what the overall plan is from the inpatient course to the outpatient setting, so that we can make sure that all the pieces are in place, so that their follow-up appointments are there, they have post-discharge recovery expectations, and we have a clear direction of what's next for them. So thank you so much. Just to some concluding thoughts, the AHA guidelines themselves are really a comprehensive review. We just touched a little bit on the overall scope of everything, but I think you can see through the overall evidence evaluation process, the goal here is to drive dissemination, implementation, so we can produce more survivors. And as we produce these survivors, hopefully we can then help them through their process so that they can have the most optimal recovery. Thank you, guys.
Thank you, Dr. Panchal, for a succinct update on the adult resuscitation guidelines. It behooves every resuscitation practitioner to follow these evidence-based guidelines for improving the resuscitation outcomes. Appreciate your contribution in developing these global guidelines as the team leader.
Thank you, appreciate it.
We welcome our next distinguished speaker, Dr. Alexis Topjian. Dr. Topjian is Associate Professor of Anesthesia, Critical Care, and Pediatrics at the University of Pennsylvania Perelman School of Medicine, and an attending physician at the Children's Hospital of Philadelphia Pediatric Intensive Care Unit. Her clinical and research focuses are on pediatric resuscitation science, specifically post-cardiac arrest care. She is the chair of the American Heart Association Emergency Cardiovascular Care Pediatric Guidelines Committee and authored the 2019 AHA Scientific Statement of Pediatric Post-Cardiac Arrest Care and the 2020 ILCOR Statement, Pediatric Core Outcome Set for Cardiac Arrest, which defines core outcomes for future pediatric cardiac arrest trials. We welcome you, Dr. Topjian.
Well, I'd like to thank you for having me. I'm going to share my screen. Let's see, 1 second. Apologies. Okay, can you see that?
Yeah.
So thank you so much for inviting me, Dr. Murthy, and members of the committee. It's really my honor to be here presenting to you today on behalf of the AHA and the numerous volunteers and AHA members that have worked to produce this updated guideline. Dr. Panchal is oftentimes a tough act to follow, but it's also been a pleasure working with him. I just want to first thank the team of unbelievable collaborators, the writing group, and those who did our international research updates and searches for this guideline. You can see it's a tremendous number of people, and I'm honored to be presenting on their behalf. So in the next 20 to 30 minutes, I'm going to talk about the process for the updated guidelines. And this will be a little bit in addition to what Dr. Panchal talked about. I'm going to review the key cardiac arrest guideline updates. And then I'm going to highlight some of the new non-cardiac arrest focused guidelines. So in pediatrics, we focused on some of the critical care management of children that are going to be quite relevant to many, many providers. So this is in the US. These numbers have been adjusted over the last year. We know that in-hospital cardiac arrest in America, and therefore across the world, is more common than you would expect. We now know that about 15,000 children per year suffer an in-hospital cardiac arrest, and survival to discharge is about 38%. We know that we've done better over the last 20 years, with survival rates about doubling, but we still have tremendous work to do. Out-of-hospital cardiac arrest, we are estimated at approximately 23,000 children per year. This is a recent paper published earlier this year in the US. But unfortunately, when we look at survival to discharge, we have not made significant improvement in outcomes. And based on the data that we look at, those rates range from 6.7% to approximately 10% and are highly variable upon age. We know that young infants in the out-of-hospital setting do much worse than our adolescent patients. So I want to just contextualize how we got to 2020. Dr. Panchal talked a little bit about this, but we did a full extensive guideline update in 2010. And then in 2015, we did a partial guideline update where we reviewed a good portion in conjunction with the International Liaison Committee on Resuscitation. So when we arrived at 2020, we knew that our process had to change. We realized that we needed to once again do a full guideline update, since it's not been done in 10 years. And with that, we changed the process. And we did things in an expedited fashion, although highly comprehensive and rigorous. And then we presented our results in a new format that Dr. Panchal showed you. So I wanted to touch briefly on how to interpret the guidelines. I think it's important to understand level of evidence. Over here on the left, you'll see our class and strength of recommendations. And what you'll see is that class 1 are our strongest recommendations, and we'll speak about those as being recommended. But then as we move down to class 2A and 2B, the strength of our recommendations and our wording changes to is reasonable or may or might be reasonable. We then move into class 3, and that highlights either no benefit or potentially harm. And we'll touch on that in several of the guidelines that we're going to look at. We also look at the level of evidence that we review, and that's going to be highly relevant in pediatrics because much of the data that we look at in children is either extrapolated from adults or is of limited quality, as randomized controlled trials are not common in pediatrics. Level A is going to be the highest quality evidence from more than one randomized controlled trial. And level of evidence, as we go down, comes down to level C, LD, which is very limited data, so very small observational trials or registry studies, or consensus expert opinion. And we have much of that in pediatrics. The causes of cardiac arrest in infants and children differ from the cardiac arrest in adults. We know that etiology is very different. We have much more respiratory arrest in children, whereas adults are more oftentimes due to cardiovascular disease. And in this update of the guidelines in 2020, we have a growing body of pediatric specific evidence to support these recommendations. This is different than in the past, where we've had to extrapolate our data from what was available either in animal studies or from the adult literature. I wanted to highlight our classes of recommendations. So you can see here in green that approximately 1/3 are class 1 recommendations for pediatrics. This is interesting because it gives us our highest strength. But as you go down, you'll see that we end up in 2B, so far less strong recommendations. And we have several class 3 recommendations, almost 10% that show either no benefit or potential harm. Interestingly, when we look at level of evidence, you can see that only 1% of our recommendations are supported by randomized controlled trials, so quite limited. And almost 50% are supported by limited data, and another 17% are based on expert opinion. This really highlights tremendous opportunities for future research to guide how we are going to care for children during and after cardiac arrest. So I wanted to touch on some key guideline highlights. Specifically, I'm going to touch on guidelines for CPR during cardiac arrest, airway management, post-cardiac arrest care, recovery, cardiac arrhythmia, shock, heart disease, and then opioids. You're going to see a lot of overlap with the adults, but I think what's interesting is that we need to think about children is completely different. While many of our algorithms and some of our guidelines are consistent with each other, which is in part intentional, we have to acknowledge that children are quite different than adults. So the first and most important is that there were no changes to the administration of high quality CPR in those guidelines. In fact, we highlight that high quality CPR is the foundation of resuscitation. You need to make sure you have adequate compression rate and depth, and there were no changes to those guidelines. You need to allow for full chest recoil to allow filling of the heart, and you want to minimize interruptions. Similar to the adults, we highlight epinephrine. We have actually several more studies than the adults do on this iteration of the guidelines. We focus on early epinephrine for non-shockable rhythms as improving the likelihood of survival. And several studies in pediatrics, both in the in-hospital and out-of-hospital setting, demonstrate that when epinephrine is given within the first 5 minutes of the initiation of CPR, outcomes are improved. Other studies show that for every minute delay in the administration of epinephrine following the initiation of CPR, outcomes worsen. So I want to highlight once again our pediatric cardiac arrest algorithm. You'll see that this looks very similar to the adult algorithm with some small subtle differences. We highlight the initiation of CPR as soon as possible for children with bag mask ventilation, and that's because we know that respiratory arrest is most commonly the cause of cardiac arrest in children. Once the rhythm is identified, you now see that under asystole PEA, in parallel to the adults, we recognize the critical need for the early administration of epinephrine because it's associated with improved survival when it is delivered as soon as possible. Likewise, on the opposing side for VFVT, we recognize that the early administration of defibrillation is also associated with improved outcomes. As we work down the algorithm, there is constant reassessment of the patient. Epinephrine should continue to be delivered for non-shockable rhythms every 3 to 5 minutes, and consideration of advanced airway should occur during that time. We constantly reassess our rhythms, and we assess for reversible causes as we move hopefully towards our patients achieving return of spontaneous circulation. An updated guideline on this iteration was a focus on invasive blood pressure monitoring to assess CPR quality. We know that in the US, that about 95% of our arrests occur in ICUs. This is very different than other parts of the world. But we know that for patients who have arterial blood pressure monitoring in place, if they're cared for in a high level of care, during in-hospital cardiac arrest, that arterial line may actually be beneficial to guiding your CPR. Previously, we had said to utilize that arterial line. This time on our guidelines, based on a high quality but small study, we have thresholds that were shown. And we recommend now using diastolic blood pressure and to titrate your CPR to diastolic blood pressure. While we're not specific on how to do that, we once again go back to the mainstays of high quality CPR, which is a rate of 100 to 120 beats per minute or compressions per minute, and the early delivery of epinephrine at least every 3 minutes. We've made pretty significant changes, and perhaps our biggest change for the 2020 guidelines is that of airway management. We now recommend targeting a rate of 20 to 30 breaths per minute when CPR is in progress for infants and children with an advanced airway in place or rescue breathing. This guideline was a change from our previous recommendation of breath rate of 10 to 12 breaths per minute. That previous rate was based on extrapolated adult data, but there was no pediatric data available when that guideline was created. And for ease of training at the time, and based on the adult data, it was selected for children. In 2019, a group of individuals looked at ventilation rates during in-hospital cardiac arrest in a small cohort of patients, about 80 patients, and they found that no patient actually received a rate of 10 breaths per minute. And then they looked at outcomes based on respiratory rate, they found that infants, so less than a year, who received a rate of 25 breaths per minute, 30 breaths per minute, and children greater than a year who received a respiratory rate of 20 breaths per minute during CPR with an advanced airway in place had higher rates of ROSC. Interestingly, if the rates got too high, they found that there was more hypotension. So we really want to emphasize that you need to be careful of not ventilating too rapidly, but we do think that a rate higher than 10, now 20 to 30 breaths per minute, may improve outcomes from cardiac arrest for children. This has been a controversial change, but one that we think is consistent with pediatric physiology. Children have much higher minute ventilations than their adult counterparts. While there was no data available for rescue breathing in a patient with a pulse, to synchronize our teaching, we also increased that rate from 12 to 20 breaths per minute to 20 to 30 breaths per minute. This is a significant change, but we think it will hopefully guide improvements in outcome for our patients now that we have pediatric data to base our guidelines on. We want to focus on not underestimating the impact of bag mask ventilation during out-of-hospital cardiac arrest. In 2019, we updated this guideline with a new focus that bag mask ventilation results in the same resuscitation outcomes as advanced airway interventions, such as endotracheal tube intubation in the out-of-hospital cardiac arrest setting. Intubation is challenging in the out-of-hospital setting, and practitioners may not be as skilled. Furthermore, delays in providing CPR to achieve an advanced airway may lead to a prolonged low flow state. While there's no evidence to support this in the in-hospital cardiac arrest setting, we do emphasize this for out-of-hospital cardiac arrest. Another significant change for 2020 for children was highlighting that a cuffed endotracheal tube should be used instead of an uncuffed endotracheal tube for intubation. Previous guidelines had focused on the placement of an uncuffed endotracheal tube. However, on review of new data, we highlighted that the placement of a cuffed endotracheal tube led to less tube changes, probably decreased the risk of regurgitation and aspiration, and was not associated with an increased rate of subglottic stenosis. So we now suggest that cuffed endotracheal tubes be used instead of uncuffed endotracheal tubes. Finally, we now recommend against the use of cricoid pressure routinely during intubation. This is a class 3 recommendation because of the concern for harm. The routine use of cricoid pressure does not reduce the risk of regurgitation during bag mask ventilation, and in fact may impede intubation success. While cricoid pressure may be used at times, if it delays the success of intubation or ventilation, we suggest that it be discontinued. So let's talk about post-cardiac arrest care. This is a specific area of interest for me. And I think when we added the 5th ring to the chain of survival several iterations ago, what we first highlighted was the resuscitation does not end when the pulse comes back, but there's in fact a period of time after that, the care needs to continue. So for our patients who have achieved return of spontaneous circulation, for all of them, even if they're back to their baseline, we want to make sure that we prevent hypotension. And for children, that is keeping the blood pressure higher than the 5th percentile for age. We prevent hypercapnia and hypocapnia, and we prevent hyperoxia and hypoxia. For children who do not regain consciousness, you should consider targeted temperature management at either 32 to 34 degrees or 36 to 37.5 degrees. We now suggest continuous EEG monitoring when the resources are available to detect seizures, as they are common after a cardiac arrest and signify brain injury. And in the event clinical seizures are present, you should treat them with anti-seizure medications. And if seizures are present on EEG monitoring or potentially non-convulsive status epilepticus, in conjunction with your neurology colleagues and experts, you should continue further treatment of seizures with the hope that you may improve outcomes. There's no data supporting that the treatment of seizures after cardiac arrest does change outcome, but we know for children with seizures without cardiac arrest, treatment with anti-seizure medications is life-saving. Finally, we recommend delaying prognostic decisions until at least 72 hours after the return to normal temperature, as cooling with sedatives on board can lead to delayed clearance and confound your neurologic exam. We're really excited to add a post-cardiac arrest checklist for providers on this version of the guidelines. We know that providing standardized care is quite challenging, especially in stressful situations after cardiac arrest. The intent of this checklist is to give the bedside providers something to work with to really think through how to guide the care of these patients. It's as simple as measure oxygenation through more advanced suggestions such as how to do TTM. But the focuses are on key components of post-arrest care, such as oxygenation and ventilation, hemodynamic monitoring, such as providing cardiac telemetry and monitoring arterial blood pressure, providing targeted temperature management, including prevention of shivering and monitoring for hypotension during rewarming if you choose to cool, neuromonitoring when available, assessment of electrolytes and glucose, treatment with sedation, and then prognosis. The hope is that individual centers can use this checklist to adapt this into providing post-arrest care in a way that fits their center and benefits their patients. As Dr. Panchal said, we were very excited to add a 6th ring of recovery. I should first say that for pediatrics, we only had one chain of survival. And on this version of the guidelines, we realized that in-hospital and out-of-hospital cardiac arrest for children are distinctly different. We know the etiologies are different. We know that the ages associated with outcome are different. And therefore, we created a new chain of survival, one for in-hospital cardiac arrest and one for out-of-hospital cardiac arrest. The focus on recovery, while important for adults, is also incredibly critical for children. We know that children's cardiac arrest happen and interrupts their development. While we may have a 4-year-old who is just learning how to do basic, speaking and interactive skills, up through teenagers who are at more complex levels, we know that development is disrupted, and we don't know how development continues after the arrest. Therefore, it is critically important, and we now recommend that after cardiac arrest, survivors have ongoing assessments of their physical, cognitive, and emotional challenges, and that within that first year after cardiac arrest, children be reassessed, not only by their pediatricians, but by providers who can help assess their ongoing development, as well as support their families as they hopefully regain some of their function. This roadmap to recovery highlights the changes that happen over time from ultra short term, which is considered early after the arrest, all the way through long term, which could be months to years following. We know our survivors grapple with challenges, not only physical and cognitive, but also with post-traumatic stress disorder, mental health issues such as depression, and impacts on the family as well as they're caring for these children. So I'd like to shift gears and talk a little bit about the tachyarrhythmias and the addition of these algorithms, or I should say the changes to these algorithms, as well as heart disease. While we haven't had any new data to highlight how we would do to treat bradycardia differently, we did make one significant change. We now highlight that the assessment of cardiopulmonary compromise should occur immediately after the identification of bradycardia in a patient. And that's because while we know bradycardia is not a problem for many patients and can actually be normal or physiologic, it's important to understand if it's impacting the patient with either altered mental status, signs of shock, or hypotension. This is oftentimes one of the most common causes of CPR for patients, or I should say the need for CPR in children, as bradycardia is quite common because it follows a respiratory arrest or hypoxia. When bradycardia is identified, if cardiopulmonary compromise is present, we want to focus on patient airway support, breathing, and ventilation, and then initiate CPR if the heart rate is less than 60 breaths per minute, despite oxygenation ventilation. If this persists, we want you to initiate CPR and continue it, and there is evidence to support administration of epinephrine, atropine for increased vagal tone, and even transthoracic pacing. While many of these patients will recover with oxygenation ventilation, some of these patients will move on to cardiac arrest. And in the event they lose a pulse, you should proceed to the cardiac arrest algorithm. We've also made changes to the tachycardia algorithm. Once again, we have highlighted the use or identification of cardiopulmonary compromise early. With your initial assessment and support, you should identify a sinus tachycardia is present because that is oftentimes the most common thing that we see in children with tachycardia. If that's identified, you should search for and treat the cause. But if it's suspected there is another reason, assessment of cardiopulmonary compromise can then help you delineate how rapidly you need to intervene. If you see cardiopulmonary compromise, you should first detect, is it a narrow or wide complex tachycardia? And from there, you should determine how to treat based on whether it is probable sinus supraventricular tachycardia or possible ventricular tachycardia. The guidelines related to these treatments have not changed on this iteration of the guidelines, although we've asking clinicians to change the framework in how they assess for cardiopulmonary compromise upfront. We have focused on sepsis in our previous version of the guidelines, and we've had some significant updates on this iteration. Sepsis is a common killer worldwide. We know based on studies for both dengue fever as well as other sepsis studies in the US, that excessive fluid administration can lead to worse outcomes. On this iteration of the guidelines, we suggest that you titrate fluids either 10 mLs per kilo or 20 mLs per kilo with frequent reassessment. The goal is to prevent pulmonary edema and fluid overload, which itself can be life-threatening. Previously, we had recommended dopamine as a first-line inotrope. We now suggest that either epinephrine or norepinephrine be used to initially treat sepsis, as outcomes are improved with patients who receive these medications. If they're not available, dopamine can still be used, but should not be used first line. Corticosteroids and septic shock has been quite controversial. For infants and children with septic shock unresponsive to fluids and requiring vasoactive support, it can be reasonable to use stress dose corticosteroids. We've added this as a new guideline because recent clinical trials suggest a benefit from corticosteroid administration in some pediatric patients with refractory septic shock. Hemorrhagic shock has also been updated. Previously, we had suggested using crystalloid, but upon review of the literature, we now suggest that it is reasonable to administer blood products when available instead of crystalloid for ongoing volume resuscitation. That's because a growing body of evidence, mostly from adults, although a little bit in children, shows that a balanced resuscitation using packed red blood cells and plasma and platelets results in better outcomes. Finally, I would like to highlight myocarditis and then more complex congenital heart disease. Myocarditis is a common killer in children. We're seeing more of it now actually in the COVID era than we had before. We think an early transfer to an ICU, the availability of extracorporeal support, whether with or without cardiac arrest, can lead to successful recovery for these children. So advanced mechanical circulation, although not available everywhere, can impact outcomes. And then new for this iteration of the guidelines, based on an AHA statement on congenital heart disease, we've added extensive recommendations on treatment of patients with single ventricle physiology and pulmonary hypertension. And while I won't go into the details here, this new addition is significantly expanded, acknowledging that although not the most common cause of cardiac arrest, these patients do require special care and special thought due to their complex physiology. Lastly, I want to touch on opioid overdose. While we didn't review data specifically to look at opioid overdose, working with Dr. Panchal and his team, we felt that it was critically important to highlight this for children as well. We know that we have children in the US and across the world that are dying from opioid overdose similar to their adult counterparts. We know that naloxone will reverse only respiratory arrest and not cardiac arrest, but we want to empower people to think about children as potentially having opioid overdose, not just adults. This is the new algorithm that's been added. So in summary, numerous new and updated recommendations have been provided for pediatrics. We are really fortunate that there's more pediatric data available now than in the past, although we have a long way to go. High quality CPR remains the mainstay of resuscitation, and that's what providers should really focus on. And there are new opportunities for research to address gaps and to improve outcomes for these patients. Thanks so much.
Thank you, Dr. Tabjian, for excellent update on pediatric resuscitation. Pediatric advanced life support is more challenging to medical practitioners due to the special skills that need to be learned and practiced for many years for better outcomes in these fragile patients. Appreciate your contribution to developing these global guidelines for pediatric resuscitation as the team leader. At this point, I request all the participants, I thank you all. Please post the questions, and I know we have got lots of questions coming up, especially from the perspective of the COVID era resuscitation. So please post the questions. And so you'll be getting the answers from the experts. So at this point, I would like to present my brief presentation on the cardiac arrest registries. And this is the first time that we are presenting this information to the international health practitioners. Okay, so let me see if I can control this from here. Looks like it is a little frozen. Give me a couple of seconds. It looks like it is an autopilot. So my presentation on cardiac arrest registries will focus on the importance of well-designed registries to initiate, monitor, and improve programs to enhance outcomes following life-threatening cardiac emergencies, including sudden cardiac arrest. Vijay, can you help us? Go to the second slide, please. Yeah, I don't have any conflicts of interest to disclose. Every year, about 350,000 persons in the United States sustain an out-of-hospital cardiac arrest. The median reported rates of survival to hospital discharge are poor, 10.4%. We need a uniform and reliable method of data collection to assess the impact of interventions to improve outcomes. The Epstein style is a set of well-designed guidelines for uniform reporting of cardiac arrest endorsed by the international resuscitation community. Under the CARES, Cardiac Arrest Registry to Enhance Survival, I will highlight the program in Illinois Heart Rescue. I will discuss two recent publications on cardiac arrest in India. One of them deals with an Indian pilot registry. I will share information on a recently completed successful pilot project, Heart Rescue India. Next slide, please. CARES is the largest national out-of-hospital cardiac arrest registry and measures performance throughout the entire chain of survival, including dispatch-assisted CPR, pre-hospital resuscitation behaviors, hospital behaviors, and intervention, survival, and neurological status metrics. For the first time ever, there is transparency in the entire chain of survival, where pre-hospital behaviors are linked to hospital behaviors, which are ultimately linked to neurologically intact survival. So without a uniform and reliable data collection, communities cannot measure the effectiveness of their pre-hospital and hospital response systems, nor can they measure the interventions they have instituted to improve outcomes and compare patient populations, interventions, outcomes, and identify opportunities to improve quality of care. Next one, please. The only previous study on out-of-hospital cardiac arrest analyzed data in Illinois was from 1980s. The state of survival in Illinois, the state of Illinois survival rates were only 2%, according to the data we collected from the Illinois Department of Public Health in the year 2012. There was no data on neurologically intact survival, and wide disparities by race or ethnicity were noticed. Next one. The purpose of the Illinois Heart Rescue study is to double neurologically intact out-of-hospital cardiac arrest survival. It's a statewide quality improvement project. There are 4 spheres that were focused upon, and data-driven activities were addressed in detail. Now, this is a graphic of the coordinating team and affiliation with University of Illinois Chicago / the University of Illinois Health. Illinois Heart Rescue was originally grant funded by the Medtronic Foundation in the year 2012. Illinois became the 7th state to join the Heart Rescue project. Pre-hospital SPEAR, you can see it here, ensures that all pre-hospital providers are practicing the standards of care, including high-performance CPR and pit crew resuscitation. The hospital SPEAR ensures that all hospitals are practicing to standards of care related to post-ROSC care with targeted temperature management, cath lab, etc. So this is the most challenging SPEAR. Community SPEAR has dramatically increased bystander CPR by hosting hundreds of community-based bystander CPR events. DataSphere utilizes the case network and collects data on the entire chain of survival. This is a more simplified graph of where the project was in 2012 with ROSC of only 2%, with the state of Illinois at that time recording the return of spontaneous circulation equivalent to survival. And there is a big jump in the year 2019, almost like 10%. And we see almost a 5 times increase in survival, a triple of bystander CPR, and a double in neurological intact status. Much more work needs to be done, but the project is making good progress. In the year 2020, the project had a bigger initiative to increase the dispatch-assisted CPR and anticipated a large bump in the overall survival. However, we are not sure how COVID will impact the overall survival numbers. The final calculations for the 2020 data will be complete in March, April of this year. Next. Next slide, please. This is a busy slide that shows more specific data, including the overall survival, overall cerebral performance category 1 to 2, overall survival when the etiology is presumed to be cardiac in nature, overall cardiac CPC, Epstein survival, witnessed cardiac arrest, presumed cardiac etiology, and found in a shockable rhythm by EMS, Epstein survival with bystander CPR. Illinois, as you can see, has outperformed the nation on Epstein and Epstein with bystander CPR. Next. Switching gears, I now turn to Indian resuscitation arena. As a co-author, I will share information on a recent article, an observational study of out-of-hospital cardiac arrest reported in Indian print media. This is published in the Journal of Indian College of Cardiology, and this is an attempt to gather any available community cardiac arrest information from the news media, specifically newspapers in India. Next. The mass media are an important source to improve health literacy in any country. This is an attempt to capture any available public information about the out-of-hospital cardiac arrest, as media play a crucial role in raising public awareness of cardiac arrest and encourage bystander help and CPR to improve outcomes. Newspaper reports from Indian newspapers in English language with a wider circulation were retrieved from the archives during 2001 to 2019. Those due to obvious possible non-cardiac causes, such as trauma, were excluded. The data related to Epstein variables were extracted from these reports, and the data of out-of-hospital cardiac arrest subjects were selected for analysis. As we can see, the cardiac arrests were recorded more in males, about 88%, and in females, about 11%. Next. The majority of arrests, about 28% of them, were seen in the age group of 51 to 60 years. Next. Majority of arrests occurred again in residences, about 33% of them, and in public buildings, about 29%. The CPR was reported in 15 cases, with 11 survivals reported to hospital admission. Next. The number of out-of-hospital cardiac arrests in the study obviously cannot be the accurate total number, as only limited information from select newspapers was available for review. There was no single agency with all needed data. Assessing the information from newspapers in different languages from different states was also a limiting factor. So the current study supports the fact that media play a crucial role in reporting cardiac emergencies in a given community at any time. The information gathered can be evaluated by the local departments of public health with or without other available data. So this may be a valuable source for cardiac arrest registries data collection in the long run. Media can promote health awareness, educational, and training programs related to cardiac emergencies and bystander emergency help, such as the hands-only CPR. I will now discuss a recent cardiac arrest registry that I was involved with as the co-investigator of this study. Out-of-hospital cardiac arrest is a global public health problem. There is inadequate data on out-of-hospital cardiac arrest in India. The Warangal Area Out-of-Hospital Cardiac Arrest Registry, WACAR, was planned to understand out-of-hospital cardiac arrest in a regional setting in India in the state of Telangana. Faculty from various departments of the University of Illinois at Chicago College of Medicine, Chicago, Illinois, collaborated with the principal investigator of the study, Dr. Srinivas Ramaka, a cardiologist from Telangana. So this is an out-of-hospital cardiac arrest registry study in India based on modified Epstein-style format. It was published in the Indian Heart Journal recently, and it also received Mendeley Fair Data Award. There is no funding for this study. Next one, please. WACAR is a prospective one-year observational cohort study of out-of-hospital cardiac arrest in the Warangal area, India. The study included 814 subjects of out-of-hospital cardiac arrest of presumed cardiac etiology brought to the Mahatma Gandhi Memorial Hospital during January 1st, 2018 and December 31st, 2018. The data collected included standard Epstein variables with additional data on clinical characteristics. So we call it as a modified Epstein template. We identified 814 arrest cases of presumed cardiac causes out of 926 total cases. The majority of cases seen in males, about 17%, were in the 51 to 60 age group, followed by about 15% in the 61 to 70 age group. Females accounted for about 9% of cardiac arrests in both 51 to 60 and 61 to 70 age groups. Hypertension, diabetes, and tobacco addiction were the major risk factors. This busy slide summarizes the resuscitation characteristics. I'm sorry, I don't think it is very legible. The available data collected has different total number of cases in each category or characteristic. Out-of-hospital cardiac arrest was witnessed in 90% of the cases, with first responder being a relative in 98% of the cases. EMS was called in 49% of them, and majority of them went to the public EMS system with the number 108. Some kind of CPR was initiated in 28% of the cases, 92% of them being hands-only CPR. Most of the CPRs were from EMS and from those who were trained previously in CPR. The time interval between witnessed arrest and initiation of CPR was anywhere between 5 to 20 minutes in 74% of the cases. EMS public ambulance availability was seen in 81% of the cases in our available data. Defibrillator was used in 39% of the cases, and there were no survivors in this study with our available data on 814 out-of-hospital cardiac arrests of presumed cardiac etiology. The Study limitations are lack of a centralized data collection and a well-designed practical out-of-hospital cardiac arrest registry system. Difficulties in accessing the relevant information from all area hospitals and other stakeholders. Out-of-hospital cardiac arrest is not a reportable event in India. Lack of data from much needed death certificates, gaps in information from the hospital records, unverifiable information from the first responders and family are some of the major hurdles encountered during the study. Despite these limitations, Walker highlights that out-of-hospital cardiac arrest of cardiac etiology is a significant public health problem in India. Walker also gives insight into the epidemiology of out-of-hospital cardiac arrest in India to some extent, and the difficulties of data collection. Initiating reliable data collection, designing and implementation of regional programs tailored to the specific needs of a particular community are essential. Public health campaign strategies to raise awareness of cardiovascular disease and sudden cardiac arrest, bystander CPR training, and public access defibrillators and timely tertiary cardiac care determine neurological and other functional outcomes. And the critical role of emergency medical services is emphasized. It's hoped that this preliminary study will generate enough interest for more prospective, comprehensive out-of-hospital cardiac arrest registries in the near future. Now I'm going to talk briefly about the Heart Rescue India project. University of Illinois at Chicago partners launched Heart Rescue India to lower the cardiac death rate in July 2015. The project was completed in 2020. The first of its kind $4.4 million 5-year collaboration funded by Medtronic Philanthropy supports community-based projects in Bengaluru, Karnataka state to lower deaths due to sudden cardiac arrest and improve access and quality of care for STEMI patients in Bengaluru area. HRI included interventions across the 3 settings of care: communities, pre-hospital EMS, and hospitals. Its catchment area included a 10-kilometer radius centered around the Ramaya Medical College in Bengaluru. HRI implemented data systems to monitor the impact of interventions on the STEMI system of care. HRI also developed a strong curriculum of community and school-based education to raise knowledge and awareness of STEMI symptoms. Additionally, HRI included 2 innovations in EMS and hospital care: an HRI nurse paramedic motor scooter EMS system with an emergency telephone number and dispatch center, a new infrastructure to facilitate faster pre-hospital EMS response to people with symptoms of STEMI, a hub and spoke referral and treatment system among hospitals, creating partnerships to facilitate access to reperfusion, which is the evidence-based treatment for STEMI patients. Under this system, 5 subspecialty spoke hospitals increased their capacity to deliver thrombolytic medications before transferring the patients, if needed, to one of the 2 hub hospitals with cardiac catheterization resources. As you can see, the STEMI arrival by ambulance significantly increased above the target in the year 2020. The number of patients reperfused also has exceeded the target number during 2019-2020. And also, there is a substantial increase of the patients that were discharged with a statin in the year 2019-2020. In summary, Under the data system activities, 1,010 STEMI patients were tracked in the HRI patient registry. 654 hospital staff were trained in data collection. We documented gender disparities in access by showing that women represented only 22% of the STEMI patients in the patient registry. Under community setting activities, 1,230 people screened for CVD risk at community educational sessions. 1,820 school children educated in school-based curriculum. 4,444 people screened for CVD risk in HRI hospitals and clinics. And informed consent from patients was taken. Under the EMS activities, 47 EMS dispatchers were trained and 588 EMS first responder motor scooter drivers were also trained. We see opportunities for further investigation, such as access to acute cardiovascular care for women, health equity, stratifying and analyzing outcomes by race or ethnicity, focus on underserved communities, continual improvement of data systems, acquisition, and use quick technology adoption and alignment to existing registries for real-time data sharing. Health worker retention strategies and integration of care for acute cardiovascular events are also the opportunities for further investigations. We see more opportunities. New HRI pre-hospital EMS protocols, ECGs, informed consent from patients, response to patient refusal of treatment, first responder clinical procedures, activating the STEMI hub and spoke hospitals response with their ambulances, HRI emergency call center dispatch procedures, data capture procedures, using the call center software, data transmission from the field to the hospitals, and checking and improving the data quality. This is my final slide. In conclusion, there is an overall recognized need for well-designed out-of-hospital cardiac arrest registries to guide community-specific, comprehensive cardiac care programs internationally. Now, these programs, when successfully implemented, will enhance outcomes after life-threatening cardiac emergencies, either in the United States or in any other country, including India. I thank all the contributors from the University of Illinois, from Telangana, and from Bangalore. And thank you all for your participation. At this point, we will have a brief question and answer session for about 15 minutes. The speakers will choose a few questions at random. We'll start with Dr. Ashish Panchal. Dr. Panchal, please.
Sure, gladly. I think Alexis and I will probably chime in on the same questions, since you'll get, that way you'll get both an adult and pediatric look at the same question. I think the first one we were looking at right off the bat is the discussion of the use of calcium in ACLS care or pediatric care. Alexis, do you want to start, and then I'll hop on the back of that?
Sure. So we once again reaffirmed in 2020 for both calcium chloride and sodium bicarbonate, they should not be routinely used. And that's because they have been shown to be associated in observational studies with lower rates of survival to discharge. That being said, there are specific scenarios in which they should be considered. So calcium channel overdose as a cause of cardiac arrest, calcium should be considered. Likewise, sodium bicarbonate can be used with some antidepressant overdoses and should be considered like tricyclics. And you'll see that in the guidelines, which I circulated the link for that, but there's specifics in there. So no routine use in PALS.
Yeah, and this is that's similarly true for adult. So we do not, again, recommend routine use of calcium for just all cardiac arrests. I think one of the fundamental things is in 2013, we did a large systematic review looking at all the data associated with calcium routinely used in arrests. And one of the key things that you saw from that is, of course, there just really wasn't any really good data to suggest that calcium really had a signal. Now, with that being said, there hasn't been any major clinical trials since then looking at calcium, so in the adult phase. So we don't really have very much data to work on from there. However, when we think about, and similar to exactly what Alexis just said, when we think about these special situations like electrolyte abnormalities, right? I think we can all agree hyperkalemia is a great example in our diabetic patients to really think about calcium treatment for those patients, right? And I think hypermag would be another one to think about. So I think those are those special situations where you would think about it, but otherwise calcium, not so much. But I do know, like when we talk to our colleagues, a lot of them are giving calcium as that last resort drug. And that's what you're seeing in the clinical trials too. So they're using calcium as this last resort drug. And so it's hard for us to really know if there's any signal there. But as of now, all that data, not really much signal. You want to hit one, Alexis?
Yeah, so why don't we just touch on diastolic blood pressure? So we do not have a specific diastolic blood pressure target. And it's a little tricky. We do say if you have an invasive arterial line in place to utilize diastolic blood pressure. The reason there's no specific target was we felt that with one study, when the diastolic blood pressure was analyzed sort of post hoc, so it wasn't utilized during the study to guide CPR, but in fact looked at after the fact and then retrospectively reviewed and was associated with outcome, we didn't actually titrate CPR to that blood pressure. So you will see in the guidelines the one reference. I don't think I would say that you should use those pressures. That being said, we do leave it open, but suggest that you look at the diastolic blood pressure. There is a growing body of literature in pediatrics that higher diastolic blood pressures during CPR are associated with higher rates of return of spontaneous circulation. So I think look at it, but you're going to have to guide your practice if you have an ART line in place. We do not recommend placing an ART line during CPR to do that. It's only if you have one in place.
Yeah, and in the adult side, very similarly, I think the concept of using hemodynamic parameters or any type of physiologic parameter to provide personalized resuscitation is new and innovative, and something that we should really look at in the future as a huge research area that's ripe for people to do large grants and large trials on. The diastolic blood pressure question for adult, we are very similarly, it's great for you if you can see during your pulse check time that you're seeing unified organized rhythm with good blood pressures, but otherwise not much benefit. And honestly, in the adult phase, a lot of it, we just don't have the data, right? We just don't have as many ART lines in people who suddenly go into cardiac arrest on the floor, or pre-hospital is a mess, right? We don't have any of that in the pre-hospital phase. Now, with that being said, to redirect us a little bit, ETCO2 is something that we have considered and used in the pre-hospital space for cardiac arrest for all ages. And we try to use it to kind of give us an idea of where we're at. We definitely use it for guidance on whether or not somebody has attained ROSC. And we've actually used numbers for ETCO2 to guide us about the quality of the resuscitation we're doing. Now, the quality of the data when it comes to ETCO2 is pretty poor. Like we don't even know if those measures that we're doing of ETCO2 are of quality measures. And so those are some of the bigger challenges of leveraging an ETCO2 measurement itself. And we even try to leverage it for determination of resuscitation paradigms, but even that's not a great measure at times. So there's a lot of question marks about how to use these things, but I think it's because we just don't have the data yet and really have the guidance to know what's the best way to do it.
So I thought I would just touch on the NRP really quickly. Our colleagues who did the neonatal updates are not here, but I think we just want to touch on their behalf, the work that they did. I think there are a couple new recommendations that were added, and you'll see that in part 5 of the guidelines on that link. I think what they highlight is that every birth should be attended by at least one person who can perform the initial steps of newborn resuscitation and initiate positive pressure ventilation if needed. I think they also highlight that for infants who do not require resuscitation, skin to skin after birth can be effective in improving temperature control, blood glucose stability. So there's really a focus not necessarily on resuscitation, but really improving the transition from the birth period. And then there, once again, updates focusing on not doing routine laryngoscopy with tracheal suctioning for babies with meconium, even if they're not vigorous. And like I said, you can find those in the link to circulation with those recommendations. Ash, do you want to tackle COVID?
Sure. Thanks for the present.
I'll let you go first.
Yeah, no, that sounds great. So I think we're all kind of struggling right now, especially when it comes to COVID. It is a population which is truly daunting and very challenging. You could see it running rampant through North America right now, and we're having full hospitals and lots of challenges associated with that. With that being said, that does impact how we think of resuscitation. So the AHA did put out an interim guidance about how to think about resuscitation of COVID patients. And so much of that interim guidance is directed at not only thinking about what we need to do for the patient, but also what we need to do to protect our providers, right? So we want to make sure our healthcare providers are well enough to continue their jobs, right? Because we're already overloaded. All we need is a large population of individuals who are now sick and no longer able to work in our space, right? And so a big part of that is to focus on good PPE use, and of course, to think about decreasing aerosolized particle generation from the procedures you're doing. So a lot of times when we think about what we would normally do for cardiac arrest, for some of my pre-hospital providers will think about using bag valve mask as their initial, followed by, taking their time to put in a supraglottic device or something like that. The concept now would be, well, if I'm using a bag valve mask, which is open to the air, I definitely am aerosolizing a lot of secretions, which could well be a COVID positive patient. Now, with that being said, we do have a little bit of sign of hope. We need to think about what the true prevalence of COVID-induced cardiac arrest in our population is, and keep in mind that this is not number one preponderance of cardiac arrest events in a lot of areas. And so you need to really kind of understand that in your specific community. If you look at the Seattle data from Seattle, Washington, what they did is they actually followed all of their cardiac arrests for a short duration of time period during one of the peaks of the epidemic that we see right now. Actually, sorry, this is from March. And what they did is they swabbed all of them after death, if they lost them or if they survived. And so they were able to look at the true COVID positivity rate of that population. And it was actually quite low. And so that gave a lot of good direction to their community to tell people, just go do CPR, and that's okay. Now, on the flip side, there's a JAMA paper about what was COVID positivity in Italy, which came up all the way up to about 20% of cardiac arrest events. So I think there's a lot of variability with there, which makes it a little challenging, but it gives you at least an idea of how you should think about it for your population. Alexis?
I was just gonna, before I touch on pediatrics, I do want to say that there's a growing body of literature that survival from out-of-hospital cardiac arrest has decreased in these environments where COVID is high. CPR is life-saving, and if patients do not present to medical care, either because they are delayed or fearful of going to the hospital, or calling 911, or people are not providing CPR, there's a very good paper out of Paris that shows outcomes over years, and COVID has been a deterrent. And being that we know that many people will not have COVID, I think it's incumbent upon us to provide CPR as safely as we can in the out-of-hospital setting to help our patients. Part of our guidelines were early on, but focused on masking when you can. And so I think it's just something to consider. For children, we focus on ventilation. We know that our children have respiratory arrest for about 90% of them as the cause of their cardiac arrest. We do not want to delay ventilation for those patients because it is life-saving, and why we initially suggested moving to intubation early to minimize aerosolization. We know that with more PPE available, that you can keep providers safe if they're adequately donned in their PPE. So minimize aerosolization to protect your providers, but high quality CPR and resuscitation is critical to saving our patients. And we encourage people to continue to do so, so that we don't see a decrement in survival and for all the advances that we've made over the last 10 years.
Agreed completely. And just to add to that, there's one last question on the same topic about whether or not we would think about Lucas or an auto pulse for these situations. First concept is when we think about mechanical chest compression devices, generally what we do is we actually do bunch them. So we don't have specific head-to-head comparisons of Lucas versus Autopulse to say one is better than the other. However, we do know that when we look at mechanical chest compression devices, the gold standard is still manual CPR versus these devices, because we are seeing in the randomized controlled trials, as well as population trials, that they are not performing as well as manual CPR. So the gold standard still is manual CPR. Now, in the interim guidance, there is recommendation that if you have a mechanical CPR device, please use it, because if you're in full PPE with gown and gloves and everything, there's a chance that you will tear your PPE as you're doing compressions. Now, with that being said, one of the big studies that we've seen out of the CARES database of the United States was that if people are not routinely using mechanical CPR devices, outcomes are poor. Like significantly poor, like we're talking statistically significant decreases in survival and neurological outcome. So if this is not regularly a part of what your normal practice is with mechanical CPR devices, be hesitant to suddenly make a huge shift, because you will definitely be taking a big hit on your CPR quality at that point.
And I think we've seen several pediatric institutions run out to buy these, but based on its height and chest diameter, that is the indication for use, there are very few children under the age of 15 that would even fit the size. It really is not just about a device, as Ash said, it's really about a system that needs to be in place for these to be effective. So not really usable in most children.
So the next thing I just definitely want to put out there, because I saw the question on it, was the use of antiarrhythmics. I love the question because we actually have good data on antiarrhythmics. So in 2018, we reviewed the ALPS trial, the amiodarone lidocaine placebo trial in adults with shock refractory VFVT. And in that study, when you compare to placebo, both amiodarone and lidocaine performed well and improved survival against placebo. Now, neurological outcome for the three groups was not different, but survival to hospital admission was different. And so that's good to see, so that we know that our antiarrhythmics are having a benefit. Now, the question was, how does it compare to bystander CPR and just basic good old fashioned BLS? I don't think it does, right? I think good old fashioned high quality CPR is still the mainstay and is going to give you the best survival benefit. Now, the use of advanced care definitely adds to what we're doing and adds to the ability to get these things. So each part is another part of that, critical part of our chain of survival that you can add to it. But again, you can't replace high quality CPR. I had one last one. Dr. Murthy, are we on good timing here?
Yes, we are.
Okay, great. So the other question that I saw in there, which I thought was a great question because I think it's great for peds and adult both, is what do you check after ROSC?
Yes, I saw that.
I love that question because I think it is so challenging. And so to start with, I think the guidance that you're getting from this guideline specifically on what you would do with post-ROSC care is quite good. With the adults, we have our new algorithm, and Alexis will comment on peds. With the adult side, what you're seeing, of course, is really making sure you have a solid airway, make sure that your respiratory parameters are reasonable and your hemodynamic parameters are reasonable. That's your initial phase, right? So then after that, of course, we're going to do the 12 lead. And the question definitely noted that make sure you get that 12 lead. And I think you're right. After that, the real question is still, is this a cardiac etiology? Because I don't think we've answered it completely with just a 12 lead EKG, right? Because that's going to tell us if there's an obvious STEMI. But then the real question is, if I'm having a patient who was in VFVT and still has cardiac compromise and things like that, my index of suspicion on this person who may well be a cardiac cripple, I don't know, because more often than not, as a pre-hospital guy, I don't have all that data. But the thing is, my index of suspicion for the etiology of arrest being cardiac is high. And so then it begs the question that do I start talking about PCI first? Now, though PCI is exciting, I think fundamentally the question you want to ask yourself at that point is, what is the etiology of this arrest, right? And so it would be great if you had a blood gas, right? Simple things being simple, right? It'd be great if you had a blood gas, if you could see what the potassium's like and things like that. If you had a point of care ultrasound, that's exciting because you can look at reversible causes, you can look at your ventricles, things like that, and look at your right side, look for PE manifestations on the heart. So looking for those etiologies are the exciting parts of that ROSC moment for, like, at least for me as an emergency physician, because then I can start kind of going through that list to think about it. Obviously, we're going to move then quickly to the other things that we know that are going to give us best outcomes, right? TTM, seizure management, things like that. But I think that finding and thinking about that etiology, which is one of the hardest like cognitive burden pieces that we have, but I think that's one of the key aspects. Alexis, your thoughts?
So I think children are a little bit different, mainly because we know that MI is usually not the cause of arrest. I think we are also relieved, especially with children, when you achieve ROSC and you have a pulse back. Sometimes people stand around congratulating themselves, and then we miss the fact that the patient is hypotensive or they're desaturated. I think the first thing is a rapid huddle with your team, assess what you need to do for that patient. So I think that a blood pressure is critically important. Hypotension, we know, is detrimental in the first 6 hours, and making a plan of what you're going to do if you have it and if you don't have it. Doing a rapid assessment of your airway, your breathing, and a quick set of vital signs, and then anticipating what's going to come next. So if you blood pressure, oxygenation, a blood gas is incredibly helpful. In the era of POCUS, we oftentimes will get a probe on the chest to assess the heart quickly, early. And then we focus on targeted temperature management early on. So a quick temperature to see if the patient is too cold. In children, they oftentimes are chilly because their body surface area, as well as concerns of could they be seizing? Do you have EEG capability to get rapid assessment? I think that checklist that we put out in this iteration of the guidelines is meant to not just tell you what to do, but to really help you think through things and guide your systems to build your own post-arrest care checklist sort of consistent with what you have available and how to think through this. And there are numerous resources available. There will be more resources coming that'll be available for people to think through post-arrest care for patients.
So I want to double back on one question. Because I saw a question on the use of lung controlled pressure volumes. So are you going to do pressure control ventilation versus volume control ventilation for COVID patients? And is there an AHA guideline on that? And I'll be frank, there isn't really a guidance from the AHA specifically on how to do that resuscitation phase, because you're pretty far down the road at this point. Because now you're dealing with issues of, is this ARDS type picture in a COVID patient, and how are you going to manage the potential barotrauma, and what kind of vent settings did you want to do in those settings, right? And from my limited emergency medicine perspective, and sadly I've been doing a lot of this lately, is looking at these patients. I think one of the big things is to really think about what your plateau pressures might be, right? So obviously your peak pressures are important, but understanding your plateau pressures also, so that you know what you're really facing when it comes to your pressures in your system. And keeping in mind, you still want to do low volume and just really make that your goal. And then from there, you can make decisions on volume and pressure. But that's just my fundamentals of critical care, right? And I think with pediatrics, it might be a little different. I'm not sure, Alexis.
No, I think that there is no right or wrong answer in this scenario. If you're in, you want a pressure limit, you want to do low tidal volume. If you're in volume control, watch your pressures. If you're in pressure control, watch your volumes. This is good ARDS management, and having a cardiac arrest is going to complicate all of that because your lungs are more injured and your heart is more injured on top of COVID. Becomes
a mess. Call for help at times.
The last question I see here is about termination of resuscitation. And I think this is a really important question, because when do you stop? Is it 20 minutes or has it changed? So I'm going to first say that we do not have a duration of CPR in pediatrics where we tell you to terminate. While we know that survival decreases with longer durations of CPR, there's good evidence from the AHA Get With The Guidelines that there are patients who have received outside 45 minutes of CPR that walk out of the hospital neurologically intact. And so while that is not the most common scenario, you have to factor in where the arrest occurred, was high quality CPR provided, and numerous other factors. So we don't use time as a hard stop. Sometimes you have patients that are in and out of a bradycardia or low flow state, but not in full asystole. And so we do not, for pediatrics, have termination of resuscitation rules. You need to be very, very thoughtful in those scenarios, knowing that survival does decrease over time, but there are cases of good recovery with longer CPR. And if you don't try, you won't find those patients.
I love that statement. That's perfect. With the adults, of course, we're a little more aggressive on the concept of termination of resuscitation, right? We see this as a part and parcel of what we need to think about as pre-hospital providers in our space, right? In the EMS space. And so we do have robust termination of resuscitation protocols. And these are also in the chapters of the guidelines that's in 2020. Now, one of the challenges, though, with these guidelines for termination of resuscitation is that they have been developed and validated, but as we look at more and more specific populations, we're seeing that the sensitivity and specificity of these rules change, right? And a lot of it is because the rules themselves are developed based on the patient characteristics, not necessarily the physiologic parameters of your patient that's sitting in front of you, right? And so there's more movement at talking about leveraging things like ETCO2 or even point of care ultrasound to help guide some of those pieces. We don't really have data on that. ETCO2 has been attempted to be integrated, but they've used it more for cutoff values. So like if you're at 20 minutes and you're less than 10 on your ETCO2, you could consider. So it's really this larger scale discussion about how to put it all together. And we don't have good enough data yet to really clearly say what it is. Now, for the 20-minute concept, so much of that data is based off of looking at larger scale studies from ROSC, where you're actually following out the time course on a chart, right? So you're looking at your survival on the vertical, time on the horizontal, and just looking at both your shockable rhythms and your non-shockable rhythms and seeing where they level out. And 25 minutes is where they're seeing that the percentage of survival becomes so low that you don't have very many survivors. But again, going back to the Get With The Guidelines data, we are seeing recoveries in the in-hospital and even in some of the out-hospital settings where people are outside that window. Well, we recognize that's probably standard deviation impacted, right? So we still don't have the best answers for this and things that we need to still research and look at closely.
And then Asha, I guess my question to you, we live in an ECMO era now,
Yes.
more extracorporeal support and eCPR. And I think some of our older data doesn't factor that in, but there are some programs and systems that have early deployment of eCPR, and that's definitely going to shift that needle with duration because of the support that patients are getting with extracorporeal support.
No, totally. And we're one of those sites. And so we will take people to ECMO at 30 minutes. So if you are resuscitating somebody who is VFBT and you think that they're refractory, so you've done your due diligence of doing your appropriate shocks, pack them and go, because if you can make it in 30 minutes to our facility, then we will put them on ECMO. And of course, we have some exclusion criteria when it comes to lactates and things like that. But I'll be honest with you, ECMO is a really challenging perspective, and really having the teams available and the infrastructure to support that is really, really challenging. We have a 24-hour service when it comes to cardiac teams. So we're one of the lucky places that has that because we're such a large quaternary care structure. So yeah, that's just one of the challenges.
Thank you both. Thank you so much. I really enjoyed, this is like a refresher course for me also, And I know there are so many questions, we got in mind, but I think, listening from both of you, who work 24 hours a day, almost 7 days a week, I think coming from your own experience and having guided as chairpersons of the respective resuscitation committees, it means a lot to us. Now, regarding the resuscitation, there are a couple of questions, Again, this is one of the earlier studies that we conducted in the state of Telangana based upon the modified Epstein style type of format. And, even though, we have been working on this for the past 5 to 6 years, the study came into fruition, that is completion. I'm talking about the WACAR project, and we had to face a lot of troubles and tribulations, because of so many reasons. As I mentioned, there was a question also about how do you compare? How do you compare the number of cardiac arrests in the United States versus India? So, well, it is just like comparing apples and oranges. And the biggest limitation we have is the lack of reliable data. And there is no single data source. So I think, but again, the whole system, is different. When I go to the rural community, there, the resources are limited. There are no private hospitals. There is one primary health center, just like what we see in rural areas in our own country here in the United States. So there is a regional disparities of distribution of equitable healthcare, not necessarily in the area of resuscitation, but elsewhere in the entire total healthcare system. That we have to accept it. But again, I think the bottom line is now for the past few years, the resuscitation system in India has taken a definite positive course. I can speak about, few organizations who have been passionately contributing to the community CPR programs. So that means a spark has already been ignited, And, first, the most important thing for us to realize, the limitations should not make us deter, from moving through our course. We have the resources limited. We don't have any mandated death certificates in India. And you go to, any kind of ambulance system, I think, they are also struggling because the traffic is a big problem. Here I can sit here and then say from Chicago, well, you guys have to do this CPR, the ROSC, 5 minutes. And my response time here in my city here in Chicago is 3.5 minutes. I cannot expect the same thing in a rural area, even in the United States. So I think we have to accept certain limitations. At the same time, we really need to develop solid, reliable data. How do you do it? Well, theoretically speaking, I don't know how challenging practical it is. You go to a community, and then you need a small registry of a community. Then go to the bigger community, and then go to the regional communities. Pulling out the data is very important for us because then you can tailor whatever you would like to give to the communities from the viewpoint of hands-on CPR. Here we can talk about, drones delivering in my backyard, the AEDs. It won't materialize even in the United States. So we have to see those limitations. At the same time, we need to have a very practical, realistic approach with evidence-based system. And I think, India is making great strides now. And I think we are hoping that more and more registries coming, and with a unified, integrated data collection system at the national level, and that will definitely at least point to certain things that could be, corrected in a practical way of reality. So with that, we will be concluding this program, and I really appreciate, our guests from India, and also our RP members, the members of the Chicago Medical Society, and also some of the international guests. And I really appreciate your presence here. So we are coming to an end of our program today. So at this point, I request Dr. John Lagadda to honor our chief guest and the two distinguished speakers. Dr. John Lagadda.
Yeah, thank you, Dr. Murthy, for your arranging today's CME. And I really appreciate the speakers for the eloquent lecture today on updates on Resuscitation 2020. At this point, I request Ms. Kodali, put the slide on, please. It's my honor to recognize Mr. John Miners for his outstanding contribution in promoting resuscitation training internationally, and welcome him as a member of OPIOID Distinguished Speaker Club. Sudhakar Janallagadda, President, OPI, and Vemuri S. Murthy, Chairman, OPI Webinar CME Committee, January 13, 2021. The next one. OPI recognized Dr. Ashish Panchal, MD, PhD, for his outstanding contribution to resuscitation education research, and welcome him as a member of OPI Distinguished Speakers Club. Sudhakar Janallagadda, President, and Vemuri Dr. Murthy, Chairman, OPI Webinar CME Committee, January 13. Next one, please. OPI recognized Dr. Alexis A. Topijan, MD, MSc, for an outstanding contribution to the resuscitation education research, and welcome her as a member of OPI Distinguished Speaker Club, Sudhakar Janallagadda, Vemuri S. Murthy. These plaques will be mailed to you soon, and will reach probably in 1 week. Okay. Thank you very much for your contribution for CM today.
Thank you, guys. Thank you for having us.
Good night.
Good night.
Night.